In this video, we will discuss how to approach a pulmonary function test. We will go into the details of figuring out if we're dealing with an obstructive or a restrictive lung disease and what specific chronic lung disease are we dealing with. Please note that this is a very simplified approach, but it should be more than enough during exam times to help you figure out what chronic lung disease the question is asking about. The first thing to note is that the most important value to look at is the FEV1 over FVC ratio. This alone can help us figure out if it's obstructive or a restrictive disease. Other values we can look at would be the total lung capacity, FEV1, and the diffusion capacity of carbon monoxide within the lungs. So if you look at this table here, we can note that the total lung capacity is always increased in obstructive and always decreased in restrictive lung diseases. FEV1 and FVC are always decreased in both obstructive and restrictive lung diseases, but one thing to note is that FEV1 is markedly decreased in obstructive lung diseases. So because of that, the FEV1 over FVC ratio in obstructive lung diseases is always decreased, whereas in restrictive, it can be normal or even increased. The first step when looking at a pulmonary function test is to look at the FEV1 over FVC ratio. If it is less than 70% of the predicted value, then it's an obstructive lung disease. If it is greater than 70% of the predicted value, it is a restrictive lung disease. Let's first look into the obstructive. After you noted that it is less than 70%, you want to figure out what type of obstructive lung disease are you dealing with. Is it asthma or is it COPD? One way you can do that is by giving the patient a bronchodilator, which is most likely a short-acting beta agonist. And once you give the patient the bronchodilator, you check the FEV1 again. If the FEV1 improves by a value of greater than 12%, this patient has asthma. If there is minimal or no change in the FEV1 after giving the patient a bronchodilator, then he has COPD. Which type of COPD? Is it emphysema or is it chronic bronchitis? One way is by measuring the DLCO, which is decreased in emphysema but not in chronic bronchitis. But it's important to note that most patients with COPD have a mix of both emphysema and chronic bronchitis. Now, when it comes to restrictive lung diseases, we're not actually going to look at FEV1 over FVC ratio directly because it can be normal in cases of restrictive lung disease. So because of that, we're going to look into the total lung capacity, and it should be less than 80% of the predicted value. Once we figured that out, we can move on to the DLCO. The reason we're going to measure the DLCO is because we need to know, are we dealing with an interstitial lung disease where the pathology is within the lung itself, or an extrapulmonary disease outside of the lungs? If the DLCO is low, then it is most likely an interstitial lung disease. If it is normal, then think of an anatomical defect such as kyphoscoliosis or a neuromuscular disease such as myasthenia gravis or even obesity. There are some cases where the total lung capacity and FEV1 over FVC ratio is normal, but the DLCO is low. In that case, you should be thinking of early interstitial lung disease, pulmonary hypertension, vasculitis, and anemia. What if the PFT is normal, but the DLCO is high? Then in that case, you can consider asthma or polycythemia. One thing to note about asthma is the methacholine challenge test. Methacholine is a muscarinic agonist that acts on the M3 receptor. In other words, it can cause bronchoconstriction and worsen the symptoms of asthma. We can theoretically use this test to diagnose asthma, but it is uncomfortable for the patient. So we only resort to the methacholine challenge test when the PFT values are normal, but there is a strong clinical suspicion for asthma.